Hello and welcome for another interview on Dental TV. And we will share it also on other social media networks because it's always interesting to talk to people like now, special guest from Brazil, Calamita, Marcelo. And I know your second name is Alexander.
Exactly.
I'm Alessandro, and you're Alexander. So basically,
Exactly.
so we have also the same name, and Calamita originally Italian, like I'm from Sardinia, so I'm also Italian. So we have the same roots.
Beautiful place.
I'm talking to you because I know you. You published also articles when I was editor in chief of the International Journal of Aesthetic Dentistry. I
Exactly.
remember already there you were talking about occlusion and aesthetics, and very interesting topic that for many years, let's say it was a little bit pushed out of dentistry. The focus one was on doing veneers, doing aesthetics, and the rest, well, it's not so important. And now these things are coming back. It's not only you, a lot of authors are talking about occlusion because we see patients having issues. So
Yes.
it's like with implant dentistry, in the beginning, people played around and then issues started popping up, and then you had to think about what is the problem, why do I have these issues. And that's why I think your book, it's already 2 years old or even more, Aesthetics in Function, integrating occlusal principles into smile design. I think, wow, 600, I already talked about that yesterday. It's about 48 pages. So this was for sure a huge work you did. And I would love to say, please introduce yourself briefly to the community, and then I have prepared some questions related to the book for you, Marcelo.
Hi, hi, Alessandro. It's a pleasure to be here with you. And my name is Marcelo Calamita. I'm a prosthodontist from Brazil. I have been working as a prosthodontist, as a dentist, and after that, as a prosthodontist for 37 years already. And I had the opportunity during the pandemic. I was promising the book for a long time, since 2000 and maybe 2014, but I never had time. And when the pandemic, when they have the pandemic, I tried to take advantage of the free time that I had, and I started to write the book. I had time, and after 1 or 2 years, I finished the book. As you mentioned, the book is very comprehensive. There's half of the book we talk about treatment planning, and half of the book we talk about occlusion, but in a very straightforward way. I try to remove the dogmas. I try to make it very practical for the reader. I have a passion for occlusion since I was very young. I translated Pete Dawson's book, the second edition of Pete Dawson's book in Brazil. We have a translation team in the university. And so I started my passion about occlusion at that time. And as you mentioned, just 1 minute, as you mentioned, occlusion now, people are revisiting the topic of occlusion because after doing static dentistry for a long time, you know that many of our failures are related to occlusion. We do what I call a high modulus of elasticity rehabilitations, and they don't behave well if the loads are not properly distributed. That's why now people are having failures. Now they are interested again about occlusion.
Absolutely. So you already answered the question, what inspired you to write the book? You told me, okay, during the pandemic, so the idea was already in your mind for many years. And during the pandemic, and we are fortunate that that you found the time, to
Yes.
write this book or write down all the information you have collected over the years. And it's also about, if I read this, I see that's a lot of essence of your daily work, of what you're doing in your everyday office. But let's come back. What do you think, or what is the idea to motivate, or what should be the main question people should ask themselves? So basically, aesthetics and function. Now it's getting one word, but it used to be like aesthetics, one word, function, another word, and there was not really a connection between the two. So what do you think made you also change your way of of looking at that, or was your focus always like the old saying, form follows function? So basically, function and aesthetics, if we talk about form of anatomy, always was a principle back in many before our time, even before our time. There was the saying of form follows function, and maybe it was lost. So what made you this up again and say, okay, now I think I have to write? Was it bad? Was it bad experience, or a lot of dentists asking you about this?
The name of the book, I think, is smart because I thought the name of the book is Aesthetics, not Aesthetics and Function. It's Aesthetic in Function. It brings some dynamic interrelationship between these two very important aspects of treatment planning and also for our treatment. So as I had a solid background in occlusion and I started doing rehabilitations, full mouth rehabilitation since I was very young because I used to work at the military police in Brazil. So we had many patients since from the beginning of my career. I recognized the importance of the occlusion during the rehabilitation. And then I was in Brazil when the aesthetic dentistry was introduced in Brazil. It was around 1993. Robert Coachman, the father, Christian Coachman fathers introduced aesthetic dentistry in Brazil. And then I started work with him. And then I used to apply all the occlusal principles during my rehabilitation that became more and more aesthetically oriented. At the beginning, I used to work with gold. It was okay, but in functionally speaking, it was wonderful. It is wonderful, actually. But and then we started working with aesthetic materials. And then I understood since from the beginning that the importance of the distribution of forces in that aesthetic materials that at that time was not the strength of the material or something like was in the beginning, the ceramics, we only had static ceramic. And then I understood that if I didn't plan it well, if I didn't adjust it well, the simply it won't last. It is starting from that time. And then I always gave a lot of priority in the function because for me, it's going to support the statics. Function is going to make the static last longer. I'm going to provide longevity only if I understand well the interrelationship between the support, the proper distribution of load into the fragile or high modulus of elasticity material that had some kind of, they are prone to have crack propagation or something like that. So
okay, so
what's the idea?
Yeah, what's the most common mistake clinicians make when they're planning aesthetic cases? So from your experience.
I think people emphasize a lot the aesthetic design. You can use we used to work like you can make like some tools like TST or Smile Cloud or some others. And they have a wonderful smile design, but they don't know how to. This is something like the architecture of design, but many people don't know how to engineer that, how to give proper support. And I think that all the time, depending on the design and aesthetic of design, not only about, I'm not talking only about dentistry, but houses or something, you have to understand that the two things, form and function, should be considered like at the same time in order for you to provide, as I already mentioned, proper support.
And I already mentioned that yesterday when I was like reviewing your book. I recorded a video reviewing your book because you were not there. So I took the chance to go through, I didn't read everything. So by the way, but I will read more in detail for sure. I made a statement and saying, look, digital smile design, we will talk about, because your book covers a lot of analog workflows that still are valid, but we need also to create the connection. We had an interesting discussion these days. If you talk about occlusion and the classic way how we record the models with all the things and have the articulators, this occlusion is not the same as a digital recorded occlusion. Because the problem of digital recorded occlusion is how much bite force does the patient have. So if you scan and you do these buccal bites, depending on how much force the patient applies, the penetration, and you see if you check the occlusion on the digital, on the computer, that you have different kind of penetrations, occlusal penetrations, and they are not always the
Mesh
same,
penetrations.
yeah, as the standard. So what is because your book is, I don't want to call it old school, but it's really the standard, the gold standard, how to do it. And what is for you the struggle to do the shift from this analog model based situation into the digital version? If you compare the two, I bet you did also cases fully digitally. Did you see differences, or do you say we can really transcribe the analog workflow into the digital workflow?
Yes, this kind of discussion, I didn't have actually time. And also at that time, I started to write the book in 2020. There was not so many publications about that, about this, especially specifically about this issue. During the last 2 to 3 years, we had some publication, not so many, that address well this kind of issue. So my idea was to give you all the concepts that you can follow, any kind of analog or digital workflow. But what you're talking about is called, nowadays you call that mesh interpenetrations or mesh penetration, which is hard. It's something that we still don't know how to control all these variables. For you to have an idea, Marta Revilla Leon just published an article last year talking about when you have a registration, a record, and you take the record with, like, for CR record with the open bite, the record is more precise than if you take the record in the MIP position, which is counter. You can see that doesn't make sense. Why? Because if you take the bite with MIP position, you have more mesh interpenetration. If you take the bite with the mouth open, with just one anterior contact, you have more precision. Nowadays, we know this kind of thing. That's why I strongly recommend, I think, the digital dentistry, one of the most, I think, more than aesthetics, digital dentistry brings you predictability in terms of occlusion. One of the main points, one of the key points about occlusion is how to take a proper record. When you are planning the rehabilitation, are you planning to take the record in CR or MIP? But if you know how to take the record, you should make it very precise. And I think that digital dentistry, intraoral scanner makes it. For me, I talk a lot about that in the lectures. For me, this is the most advantage that you have during the digital workflow. Taking the bite, the amount of error that we introduce in this registration is much less than we introduce during the analog workflow because of the distortion of taking the bite itself in the mouth, and also the distortion of the materials that you work in the laboratory. So this is, for me, it's the most important thing. Actually, the most important thing, the full mouth, the rehabilitation, is how to take it's just because everything is going to start from this point. For me, it's the essence.
Yeah,
And there is
absolutely.
a lot of dogmas.
But at the end, we have, and your concept is not so bad to say, okay, we have the two arches, and basically you can even let the software try to put the two arches together, trying to find the maximum intercuspidation, and then check if this digital mounting corresponds to the clinical situation. Because I think you always need to double check whatever we are doing. It's, if you make a tailor-made suit, before it's really finished, there's a try-in, and you might do some small corrections. Something is not perfectly fitting, and the same applies to any work we are doing. So it's not like doing a full mouth rehabilitation and then you get it from the lab, you cement it, and everything is perfect. You always have to check. And I think it would be interesting to see, or to maybe do some research. Maybe your colleague who's publishing a lot in CAD/CAM dentistry, Maria, she's doing a lot, and this could be a question we could ask her.
So, but what they're saying, I agree 100% with you. But look, many dentists don't pay attention to something. As I mentioned, for example, I take the bite CR registration to make a full mouth rehabilitation with provisional, additive and provisionals or MMA or whatever. The amount of time that I have to adjust a full mouth provisional mouth is much less than I used to have when I use the analog workflow. But look how interesting it is. Sometimes you are just making an impression. I scan for a single implant or for a single only or something like that. And then you have problem with the simple, super simple registration. Then we have the implant with under occlusion. And you have the implant with super occlusion. It's how can I have a problem? And it's very frequent. It's not unusual to have issues with single or two units in a dentate mouth. Why? Because we have this kind of mesh interpenetration that you don't know how to control it properly. So I have to remake many times because it's infraocclusion. We cannot accept any kind of restoration with intraocclusion because if you put that, you're going to create some kind of instability in your system. So you have to remake it. But when I'm doing a full mouth, it's the amount of adjustment is much less, but always have adjustment, right? We always have to adjust, always.
Yeah, basically it's more you have to check. A lot of people are not controlling their work. Basically, you cement the restoration and you're happy that everything is finished and you send or you tell the patient, do a little bit club. It's okay. Yes, it's okay. And the patient goes home. Maybe we should pay a little bit more attention also on the details. And again, if you do a large reconstruction, you have invested some time, the patient has invested some money, so it deserves this extra amount of effort to do the final check, which often is a little bit overlooked. And
frequently, even good dentists, I have some patients from them, it's a wonderful, but they don't pay attention to the occlusion. If the patient say, it's okay, doctor. Okay. That's okay. It's okay. No, you have to check. You're doing check. You're going to see that it's not okay.
Yeah, but it's interesting in this context. When I was a student, maybe you remember the story of the Scandinavian countries throwing out the face bows from the window and telling there's only one occlusion style, which they called, and I think some universities still call the feel-good occlusion. So basically, if the patient feels good, you ask the patient, close your mouth, move around. How do you feel? And then the patient tells you, yeah, I feel fine. I don't feel any interferences. Everything is good. And they say, then it's okay. And sometimes we force, let's say, especially in the German culture in the 80s and 90s, with very mechanical or mechanistical philosophies, which did not really respect the biomechanical part of our occlusion, of how the TMG really works and so on. So I think there's not one real concept of occlusion. Or what is your statement? If reading this, you also have the freedom in centric. What would be your concept? Or basically the other question, the occlusal concept has a lot to do with the materials you use. Is this correct?
No, the concepts are pretty much the same. People used to say that your composites are more straightforward because I think composite is easier to adjust and easier to polish because it's like softer, so it's super easy. But in terms of transmission of force for the periodontal, it doesn't have anything to do. I think if you have a very well adjusted ceramic, it's the same. But ceramic is very super harder to adjust and also very hard for you to polish. And ceramic must be very well polished in order for you not to have more friction and also diminish the amount of crack propagation. So that's why. But I use ceramic most in my practice around 95% of my time, only for small restorations, direct restorations, composite all the time. But for indirect restorations, I like to use ceramic, and I strongly recommend if it's properly adjusted, no problem. But the thing that you mentioned is very important. We don't need to be super mechanistic, go in that direction. We have to have tripods all the time. You have to have ABC context because in the nature, it's super rare for you to find this kind of tripods in the nature. It was created by human. Right. Actually, for eminence, it's an eminence-based concept, not evidence-based, because some people during the 50s, 70s, 60s tried to, I discovered the holy grail. I discovered that if you have tripods, the system will behave better. It's going to behave better than if I don't have. So like Peter Thomas or something. And you don't know that's not necessary. So nowadays you try to use what is called a simplified occlusal concept. It was like published by Wiscott and Belser in 85, something like that. I think it's more than enough. We have to look for stability. And if you have at least one point of contact per tooth is enough. But one thing that is important related to your first statement is the dentist should not introduce any kind of interference, should not introduce any kind of prematurity. If the system is there, the patient is okay, doctor, it's okay. It's okay because it's adapted to all the interference that started to happen when the patient was in the growing, during the development, growing and development phase. But the dentist is going to introduce an interference from one day to the other, and some patients cannot adapt well to this. Don't not introduce an interference, and do not remove an interference if the patient is adapted to it.
Because I was more asking about the concept, for example, the canine guidance or group guidance. So recently, there was interesting studies also that 80% of our patients don't have a canine guidance as their standard. So basically, yes, a lot of principals are saying we need a canine guidance. Recently, with hybrid materials, with composite, with all the things that are popping up, more people are saying we tend to do like a group guidance. But again, I think the point of what the patient feels better with. I think there's not one solution, because if we look at the evidence, canine guidance is something that is not the majority of our patients having it. So there's a research on that. So canine guidance is not natural. But a lot of people are saying you need to include canine guidance in your restorative concept. But again, I think there are many ways that lead to Rome. At the end,
Alessandro, what you're talking is very interesting. But if you take a look in my book, I did a very nice review about that. A very nice review about the pros and cons of using canine guidance versus.
That's why I'm asking.
Yes, the canine studies that some of them comes from the 60s. It's not so new. Some from the 60s, and the other good studies comes from, I think, from the 80s. Young patients tends to have canine guidance. From 40 years old on, they tend to have good function. Why? Because of physiologic wear. It's not pathologic wear also, but physiologic wear. And then when I try to restore those patients, we tend to use canine guidance, although it's not so natural for people older than 40, is because it's easier. It's much easier for the dentist to design and to adjust a canine guidance. Group function, it's super hard for you to do in the laboratory. Nowadays, depending if you use some kind of jaw tracking device, if you use axiography, okay, a little bit easier to do. But for most of the people, for the vast majority of dentists, I used to say 95% of the dentists, canine guidance is more than enough for you to provide a physiologic, let's say, occlusal scheme. It will be comfortable enough. It's going to be long lasting. You're going to concentrate the forces far away from the fulcrum, which is very favorable. Canine is because it's good tooth because the roots are bigger. You have very good proprioception, many advantages. That's why. But most important, is easier. That's why I use canine guidance.
That's a good point. Let's talk about something that is not covered in the book, but I'm wondering what your thoughts are about AI tools getting more and more popular. Sometimes even things are called AI that are not AI at all. So something is sometimes interesting that a software that we used for many years now is an AI tool. Before that, it was like just a software. Now it's an AI tool because it sounds cooler if it's an AI tool. So, what AI tools or digital technologies do you see having an impact in our treatments in the future? I'm not talking about because AI, the most part of AI is in diagnostics. So this would be then in the treatment planning, but this was not a part of the book. So basically, where do you see these AI tools having impact your workflow?
Yeah. For diagnosis, I think it's advanced and it's going to reduce the amount of underdiagnosed things because sometimes we don't see it, the X-ray, we don't see it, the CBCT. So it's going to highlight. But again, there are some hallucinations and the AI, some kind of proposal that you have to have a solid background and knowledge in order to balance what is relevant and what is not relevant. So I think it's important. But for us, for example, we have more experience. I think if you use AI in order to to improve our diagnostic capacities, I think is going to be it is nice, but it's going to become more and more important. For occlusion, sincerely, for now, I don't know anything that they use a really AI. They have some kind of tools. They propose some advantage that some of them are not important at all. There are much more like selling strategies that's going to propose really, that is going to propose very relevant and it's going to make the difference at the end of the treatment. So for now, I don't know if you do. I don't know anything that use AI in order to improve our occlusal diagnostic skills or
So basically, it would be something like you see with aligner in this treatment planning softwares. There's a lot of AI. I know that, for example, Align has, I don't know, 17 million or even a larger number of cases that are part of the software. And the software learns from all the cases to give better proposals to the dentists. So do you think there will be something similar also in the restorative dentistry?
I think that some of jaw tracking devices, they are promising something, but until now, we don't know the real advantage of it. Why? Because if you think about this tool is nice, they are very nice, fancy gadgets. Some of them are fancy gadgets that can propose, okay, you can have you can have all the inclinations of the cordial guidance and a Bennett angle or something like that. Yes, it's true. But they don't take, for example, we don't have that so far. They take 100 patients and they say, look, before the treatments or these 100 patients, all of them class one with the same kind of problems, we have this kind of advantage. All after treating 200 patients, we have this kind of pros and cons. They only say that it's good. They only say that the number is going to help you. Yes, it may help you, but we don't know the extension of that. I don't know. I don't know. There is no paper. There are no papers about that. We don't know how it can help the dentist. And many people are investing a lot of money in this kind of equipment without knowing the basic principles of occlusion. That's why I have some argumentation about this.
Okay.
It's like you, for example. If some people, you have many for question you, Alessandro, what kind of camera should I buy? Depends, because many people that are going to that is contacting you, many of these people don't know how to take a single picture with a cell phone. And then they're going to ask you, you can recommend that one camera that costs 1,000 euro or other camera that can cost 7,000 euros. It depends on you. It's the same thing with occlusion. In the jaw tracking device, I can ask the people, do you know how to use an articulator, €1,000 articulator? Do you know how to master all of the limits of the articulator? Yes. Do you have any problem? Yes, I could prove a little bit better, more. And then you can recommend, but people don't know how to use the base. And then they want to invest 30, maybe sometimes €30,000 in some equipment that they don't know the basics. So that's why I had this some kind of argumentation.
No,
I don't know if you're good.
that's completely right. Because I had today a dentist visiting me from Munich, and we talked about aesthetics and aesthetic planning. And then I showed him, a book from 1982, the Aesthetic Guidelines from Peter Scherer, Rin and Kopp. You know this book?
Amazing. I love, of course. Amazing.
And you know
I love it.
the table that is inside with this design. This is something that then Pascal Magne took over. Everybody was like copying the same thing because it's something that is 100 years old.
Yes.
And then also coming back to the digital smile design. And I made the statement when I was reviewing your book, say, digital smile design, basically, if you want to learn about digital smile design, get yourself a textbook on full denture.
It's
Because
Lombardi. It's
yes,
Lombardi. It's come from the 70s.
absolutely. Because then you know that setting up the front teeth is what you need to do. So you define the form, you define the function, the phonetic, everything, the vertical dimension, everything is defined by putting them in the right position. And it's interesting also the function is defined by the front teeth. That's why, for example, I had discussions also with Francesca Vailatti about her 3-step technique. Should you start restoring the back teeth or should you start restoring the front teeth?
My opinion is front teeth, of course.
Front teeth first. But a lot of people, if they raise the bite, they do the back teeth first and then the front at the end. And what the result is that you open the bite way too much in most of the cases. And then the front teeth are getting like massive. And that's why I always say, do what we learned with full dentures, reconstruct the front teeth, give them their anatomy back. And with this, and this was also in your article in 2019 about the interocclusal relation of the front teeth, giving you the relation, and then you see how much space is there left in your back teeth. And sometimes it's even, you can just put a little bit of composite and you don't need to restore or do heavy restoration. So basically, this is what I learned also reading your article or reading art from Francesca. Francesca has evolved or developed her system, but basically more and more people are taking also care about occlusion and the connection between aesthetic but I like your small difference. It's not aesthetic and function, it's aesthetics in function. So basically this was a good reminder in the beginning of how to read the title of your book. So to end up this interesting discussion, I always ask my guests, so what advice do you give to the younger generation? So is it all about aesthetic? Is it all about occlusion? Where should they start? Because I see a lot of young dentists are like a little bit disappointed because they think, okay, now I'm a dentist and now I also want to do this full mouth rehabilitations and this and Hollywood and whatever. So what are your advice? Because interviewing people also like Nazari told me in the beginning he was doing single crowns and he did the crowns for free to learn. And I think this is something that impressed me, that all people that made a career started very low. And also your career is interesting that you started in the military where you had the chance to do work that maybe in the normal field of dentistry, you wouldn't be able doing so. So what are your advices to the younger generation? What should they do?
So the problem nowadays, I think, is social media makes the young people very anxious and they want to make everything very fast, and they want to become even wealthy, even rich very fast. This is the problem with dentistry. Dentistry, I think it's a long-term career. You have to build every block, and you have to have some kind of long-term goals. And then you have to recognize your limitation and you start from scratch, having very good mentors, follow people that not like gurus from the internet, but people like put very good quality of information like you with photography, like Marcus Platz with vision and everything. So have good mentors, have a solid background. I think we should invest a lot of money in the knowledge. And then to get some experience, as you mentioned, Nazari, I had the opportunity. I think military police made all the difference for me because I was very young and I had many different patients to do whatever I wanted because the military people, they they are very nice people. They agree with everything. And then you had to get experience and to be one thing that I like to emphasize, don't stay only with one philosophy, because I used to travel a lot and then I see that some people from Eastern Europe, they follow some guys and take some schools of occlusion. They take that like a religion. Some of them go to the United States and they follow another kind of school that they become like a religion. So we have to visit, you have to do course with different people because the truth is in the middle. No, there is not such a one group that owns the truth. I think you have to know different philosophies and to take the best that you have from each philosophy and to build your own. As I mentioned, one good mentor can help you, but please don't trust in one person. Don't think that they know everything because we don't know everything. So that's another good point.
Perfect. So that's it. And now you're in the US.
No, I'm in my office. I'm in my office.
So you still were, because I saw in your curriculum that you had also once you were also in the US, in Florida. Is that correct?
Yes, I'm visiting professor at University of Florida.
Ah, okay, I see. Okay, perfect. Super. Thank you very much for taking your time. I will take a
It
deeper
was a
dive
pleasure.
into the book. There's so many things to learn. And let's say, I always tell people, never stop learning. It's always interesting to talk to people like you. And for sure, this will not be the last time that we will have a chat. And I will come back with some questions for sure.
No, come on. Yeah, yeah, whenever you want, and congratulations for everything you have been doing after leaving the International Journal of Aesthetic Dentistry. I am your fan. I was your fan as an editor in chief. You have been editor in chief for a long time. I don't know, 10 years. How many?
16 years.
16 years, amazing. And then after that, you you mentioned that you and your wife didn't want to come back again to the social media when have been doing a very nice work. I love to see your posts. I learn a lot with you. Congratulations and thank you also for
Thank you very
everything you
much.
have been doing.
Thank you.
Okay.
Okay. Thank you. And
Bye bye.
see you soon. Take care. Bye bye.
See you soon. Bye bye. Keep in contact. Bye bye.